respected delegates for this beautiful scientific session. Now I'll request Anu sir to proceed further for this session. Thank you. बहुत बहुत शुक्रिया इरफान जी। वो कहते हैं कि बिना किताबों की जो पढ़ाई सीखी जाती है उसे जिंदगी कहते हैं। जिंदगी एक हसीन ख्वाब है, जियो तो जीने की चाहत होना चाहिए, गम खुद ही खुशी में बदल जाएगा, मुस्कुराने की आदत होना चाहिए। आप सभी को सबसे पहले वर्ल्ड डायबिटीज डे की हार्दिक शुभकामनाएं। A very good evening, my senior doctors, my dear friends. I welcome all the augustly present for today's scientific feast on the behalf of Association of Physicians of India Jhansi chapter and the courtesy by Corona Remedies. The topic for today's CME is fate of solitary kidney. I am privileged to invite Dr. Professor Dr. P.K. Jansi, President API JHANSI on the dais, sir. कि अनुशासन कठिन जरूर लगता है, पर आदत बन जाए तो सफलता की। And I take honor to invite Dr. Satish Agrawal sir, the Honorable General Secretary API JHANSI chapter on the dais, कि जीवन दो पल का है, जियो तो फूलों की तरह, बिखरो तो खुशबू की तरह, और वो हमारे सतीश सर है। चाहे मेरे को नहीं पर ताली से अभिनंदन। And I take honor to invite the chairperson for today's evening. I invite Dr. Nutan sir to kindly come and take his respective seat. कि खूबसूरत लोग हमेशा अच्छे नहीं होते, लेकिन अच्छे लोग हमेशा खूबसूरत होते हैं, वो नूतन सर। Now I take privilege to invite Dr. Rajat Jain sir, the Professor of Medicine at API JHANSI, to take his respective seat. कि जिंदगी हमें खूबसूरत दोस्त देती है, लेकिन अच्छे दोस्त हमें खूबसूरत जिंदगी देते हैं, बुरा जैसा है। I take honor to invite Dr. Ram Babu sir, HOD Department of Medicine, Medical College Jhansi। आज इनका API JHANSI हृदय से नंदन वंदन अभिनंदन करता है। Now I take honor to invite the regional manager Mohammad Irfan to kindly present a bouquet to our respective President of API JHANSI, Dr. P.K. Jansi, with the bouquet. स्पीकर के लिए तो अल्फाज नहीं हमारे पास। Now I take honor to invite the bouquet to our respective Professor P.K. Jansi. I request Mohammad Irfan to kindly present a bouquet to our respective General Secretary API JHANSI, Dr. Satish Agrawal sir. I request Dr. Anshul Agrawal to come forward. Dr. Anshul to come forward and present a bouquet to the star speaker of today's evening, Dr. Satyanand जी। कि जीवन एक संगीत है, इसे गुनगुनाते रहिए, हालत जैसे भी हो हमेशा मुस्कुराते रहिए। I take honor and request Dr. D.S. Gupta sir to come forward and present a beautiful bouquet to a chairperson, Dr. Nutan Agrawal sir। चाहेंगे शानदार ताली से उनका अभिनंदन करा जाए। Now I request Dr. Vinod Sahu sahab to come forward and present a bouquet to a respective Dr. Ram Babu sir। शानदार तालियों से अभिनंदन पुनः एक बार। Now I request Dr. Rajan Badal to come forward and present a bouquet to a respective chairperson of this evening, Dr. Nutan Agrawal sir, Professor Dr. Nutan Agrawal. हो गया Dr. Rajat, and I'm really sorry sir. Sorry. And I request our Honorable President sir for the shower blessings for today's evening, sir.
all for this evening. We are meeting after a long time. We couldn't do, because of some other reason, any meeting in the month of October. And this month we have planned for 3 meetings. This is our first meeting. The topic we have chosen today is fate of solitary kidney. It's of great clinical relevance. Reason is whether the solitary kidney is congenital or acquired. But it poses a lot of challenges, unique physiological adaptations and challenges for the future of the patients. Understanding these mechanisms is essential for all of us who especially treat diabetes, blood pressure, renal disorders or post-surgical cases. And we are very fortunate that we have with us today our learned speaker, Dr. Satyanand Sathi. Again, I am proud that he is our own product. He passed his MBBS from this institute only, Medical College Jhansi, in 98. He joined this MBBS and then he did his MD from Agra and then DM nephrology from Delhi. He is a well-known nephrologist there. I am sure that he will enlighten us why this topic is important, why he has chosen this topic, and we all know, eager to know what are the different mechanisms, what are the reasons behind it, what are the reasons why it causes number of problems in time to come in good number of persons, whether it is hypertension or some other lot of other problems. So his experience will enlighten us with all these problems. At the same time, I welcome all my chairpersons, including Professor Nutan Agarwal, Professor Ram Babu, Professor Rajat Jain, and we are expecting even Professor N.S. Sangra. He is just coming. At the same time, I welcome you all for joining this meet, and I'm sure you will learn so many things from our learned speaker about it, and especially we will also listen some comments from our learned nephrologist, Professor Sanger and Professor Nutan also. Thank you very much.
Now I request our chairperson to kindly introduce our respective speaker today's evening. So I request our chairperson to kindly chair the session and request our honorable speaker of today's evening. We invite him on the podium to kindly deliver his lecture.
Yes, sir. Please present a small.
He become a head of department of medicine. API welcome him.
A small gesture for medicine department.
सबने वो नहीं जो सोते समय देखते सब.
We deal solitary kidney patients, and sometimes young adult patients comes to you with ultrasonography reports. Doctor, I am having single kidney. It was incidentally found on ultrasonography. And he or she asks, what will be the future of my kidney? Is there any harm in future? What precautions should I take to avoid the further complications? Or it is all right, there is no problem in having single kidney, solitary kidney. When I was DM student, I used to write the diagnosis like right-sided single kidney, left-sided single kidney. But the standard term is solitary kidney, congenital solitary kidney right-sided congenital solitary kidney, or right-sided acquired solitary kidney. Single kidney is not the standard terminology. So solitary kidney may be congenital, that is by birth, or acquired. Acquired means acquired by after nephrectomy. The single kidney remaining after nephrectomy is known as acquired solitary kidney. Solitary kidney is important because it has fewer nephrons in comparison to person with 2 kidneys. And all of we know that GFR is the fundamental property of the kidney, and GFR, glomerular filtration rate, depends on age, sex, race, muscle mass, serum creatinine, and number of nephrons. Higher the number of nephrons, higher the GFR. Lesser the number of nephrons, lesser the GFR. So that is the important significance of solitary kidney. Because solitary kidney have lesser number of nephrons. Congenital solitary kidney patients are sometimes associated with congenital anomalies of kidney and urinary tract. This is another problem. Some patients, they have associated anomaly of kidney and urinary tract. And some patients also have associated genital anomaly with kidney genital anomalies. The reason behind that is embryology. Genital system and renal system develop simultaneously. A substantial portion of solitary kidney patients remains at risk of CKD progression. And this is the most important point. That's why the topic is going to discuss. There are great challenges. What are the challenges? The first challenge is to distinguish the patients who are at high risk of CKD progression from those who are not. Second challenge is which solitary kidney, congenital versus acquired, is a lifetime greater risk for renal disease progression, or risk is for both congenital and acquired. Third problem is that proper guidelines and consensus are not available, unfortunately, for the management, follow-up and long-term outcomes of these patients. So in short, it is very important to understand the embryology of kidney before going into detail. In short, I will try to explain embryology. During 4th week of gestation, urogenital ridge leads to the formation of nephrogenic cord and gonadal ridge. Out of them, nephrogenic cord gets differentiated into pronephros, mesonephros, metanephros. Out of them, mesonephros, during 5th week of gestation, mesonephros form the mesonephric duct, also known as Wolffian duct. During 5th week of gestation, in presence of metanephric blastoma, that is an aggregate of intermediate mesoderm, the mesonephric duct, Wolffian duct, gets stimulated to develop an outgrowth ureteric bud. So here two things are important. First is the nephrogenic cord, second is the ureteric bud. Because ureteric bud will form the entire structure of the kidney. If any embryonic insult during antenatal period causes failure to develop the nephrogenic cord or failure to develop the ureteric bud, the kidney development didn't take place. Another most important thing is parallel to the mesonephric duct, there is development of paramesonephric duct, also known as Mullerian duct. It develops from the coelomic epithelium. And mesonephric duct in male
Now I request Dr. Alok Sharma sir to come forward to kindly present the bouquet to our respective.
Sir, it's not nice to interrupt the...
So in continuation with development of ureteric bud from the mesonephric duct, the mesonephric duct also develops into epididymis, vas deferens, seminal vesicle, ejaculatory duct in male, but degenerates in female. In female, another structure, paramesonephric duct, that is Mullerian duct, develops into uterus, fallopian tube, proximal third of vagina and cervix in female. So it is very important, we should keep in our mind whenever we encounter a patient of congenital solitary kidney, that particular patient might have associated Wolffian duct derived structural anomaly in male or Mullerian duct derived structural anomaly in female. During 6th week of gestation, ureteric bud develops into the basic architecture of the kidney, upper pole, lower pole and minor calyces. During 7th week of gestation, ureteric bud further develops into the fundamental structure of the kidney, that is nephron. Bowman capsule, proximal convoluted tubules, lupo family, distal tubule collecting ducts. Entire structure of nephron is formed during 7th week of gestation from the ureteric bud with major calyx. We can say that urine formation in fetus starts during 7th week of gestation because nephron formation has been completed during 7th week of gestation. And this process of nephrogenesis continues up to 36 weeks of gestation. So up to 36 weeks of gestation, the nephrons successively add on in the fetus to the kidney, inside the fetus. So we can say after the 36 week of the children who born after the 36 week of gestation, they will have lesser number of nephrons in compared to children who will born after 36 week of gestation. So children born before 36 week of gestation may have fewer nephrons, and during embryology, before 6th week, kidney lies in sacral region, and they reach the lumbar region by ascending between 6th to 9th week of gestation. And if this ascending didn't take place, then there is ectopic kidney. Kidney in fetus lies in pelvic region. Then they ascends up with the development to the lumbar region. Low birth weight and prematurity represent low nephron number, and again low nephron number is a risk factor for hypertension, chronic kidney disease in middle-aged adults. Preterm and extreme preterm number both are risk factors for chronic kidney disease from childhood to adulthood. So congenital solitary kidney is anatomical or functional absence of one kidney by birth. It occurs due to absence of nephrogenic cord or failure to form the ureteric bud due to some kind of amniotic insult during antenatal period. And it may be associated with other, as I already told, mesonephric duct or Wolfram duct derived structure anomaly or Wolfram duct derived structure, epididymis, seminal vesicle, ejaculatory duct, vas deferens. And Mullerian duct derived structures anomaly means uterus, anomaly of vagina, anomaly of cervix, we can find with solitary kidney patients. Genital anomalies are further 3 to 4 times more frequent in female as compared to male. And incidence of congenital solitary kidney is 1 in 1000 births, more common on left side, and male predominance is found. We should be aware that congenital solitary kidney patients might have associated anomaly of renal and genital system. 1/3 cases of congenital solitary kidney are related to congenital anomaly of kidney and urinary tract, and 30% patients of Vater syndrome are associated with congenital solitary kidney. In Vater syndrome, V4 vertebral anomaly, A4 anal atresia, T4 tracheoesophageal fistula, E4 esophageal atresia, R4 renal anomaly. And Vector is the extended form of Vater. In Vector C4 cardiac anomaly and L4 limb anomaly like radius anomalies. Sometimes congenital solitary kidney associated with congenital absence of vagina and uterus, known as Mayer-Rokitansky-Kuster-Hauser syndrome. Vesicoureteral reflex is most common urological abnormality found with congenital solitary kidney. Adrenal gland is absent in only 10% cases of congenital solitary kidney because of different embryological origin. Adrenal gland has different origin from the. So congenital solitary kidney may be in the form of aplasia, agenesis, multicystic dysplastic kidney. Aplasia means poorly developed primitive type kidney. Agenesis means complete absence of kidney, and multicystic dysplastic kidney again poorly functioning kidney. It has lobulated renal contour, renal parenchyma, pelvis, multiple non-communicating cysts, but there is a lack of blood supply. Proper blood supply is not there in multicystic dysplastic kidney. So congenital solitary kidney may be found in either form, aplasia, agenesis, or multicystic dysplastic kidney. Now this is the important point. If no additional abnormality is found, then this is rule the congenital solitary kidney will grow. Then there would be the compensatory enlargement of congenital solitary kidney. And this process of compensation starts in utero from 20th week of gestation and continues till adolescence. It occurs due to hypertrophy or increase in the number of existing nephrons. Although exact mechanism is unknown, therefore the term compensatory enlargement is preferred over compensatory hypertrophy. This was a study in pigs. Compensatory growth of congenital solitary kidney in pigs reflect increased nephron number rather than hypertrophy. In this study, 32,000 slaughter pigs were included in the study, and 7 congenital solitary functioning kidney were taken. And for control, 7 normal kidney out of 2 kidney, pig having 2 kidney, and they took 1 kidney as a control. And they observed that in congenital solitary function kidney, the number of nephron was 50% higher as compared to the single kidney of out of 2 kidneys of pig. And the number of nephron in congenital solitary function kidney was 75% of 2 kidney as compared to 2 kidney. So number of nephron solitary kidneys, first of all, approximately 40 years before, Brenner and co-worker proposed the hyperfiltration hypothesis on the basis of renal mass reduction experiments in rats. A reduction in the number of nephrons leads to the compensatory enlargement of remaining nephrons and glomerular hypertension. Keller et al. Supported this hypothesis, and they observed that patients of primary hypertension had increased glomerular volume and decreased nephron number in comparison to patients without primary hypertension. Animal studies have confirmed that congenital solitary kidney has compensatory increase in the number of nephrons. However, total number of nephrons of congenital solitary kidney are still lower in comparison to 2 kidney. There was a study conducted by Vaughan and Warren et al. This study was done in pig, and they observed the number of nephrons in adulthood of the pig, and they observed that the number of nephrons in congenital solitary kidney of pig was 75% as compared to the 2 kidney. After that, Douglas and Denton, they did the study in sheep, and they reported the nephron number in infancy. What they did nephrectomy in utero. In fetal life, they did the nephrectomy, and the sheep born with the 1 kidney, because nephrectomy was done in utero. And then they reported the number of nephron. Again, it was approximately 72% in comparison to 2 kidney. Another study was conducted by Larsen et al. They studied in rats, and they studied rats after their birth. In neonatal period, they did nephrectomy, and they studied the number of nephrons in their adulthood. So after birth nephrectomy resulted into the number of nephrons only 52% in comparison to 2 kidney. This is the significance of this study. So in crux, if a healthy person has 100% nephrons in both his kidney, then person with surgically acquired kidney would have 50% nephrons. But the congenital solitary kidney patients would have 75% of nephrons of 2 kidney.
एक किडनी 1.5 किडनी के बराबर है।
एक किडनी congenital solitary kidney.
हाँ CSK
Acquired में 50.
फिजिकल की बात ही खत्म नहीं है, बट यदि CSK है तो वो एक किडनी 1.5 किडनी के बराबर रेफरेंस लिए थे।
हाँ 70%. So congenital solitary kidney, CKD progression among the children with solitary kidney. So CKD has reduced, congenital solitary kidney has reduced number of nephrons, and at the risk of proteinuria, hypertension, declining the GFR over time. Approximately 1/3 of the adults with congenital solitary kidney have proteinuria, hypertension, or impaired kidney function. There was a study conducted by Hutchinson K. et al. They analyzed the 45 previously published studies, and they observed that 7.4% of children had hypertension, 8.4% had decreased renal function, and 10.1% proportion of children had proteinuria. And this was very landmark study, Kimono study, kidney monofunction study. This prospective longitudinal follow-up study was conducted in Netherlands. They included 400 children, and they included both acquired solitary kidney patients, children who underwent nephrectomy in their childhood, and then follow-up. And they included congenital solitary kidney patients.
किस साल की स्टडी? सिंगल किडनी के साथ।
So 16.
Huge number of kidneys.
16. What they observed fall in GFR occurs usually after the age of 9 years, while microalbuminuria was found after the age of 16 years. This is the reversible epidemiology. Usually in nephrology, in glomerular disease, first proteinuria, whether it is diabetes, also glomerular disease, and after years of proteinuria, there is a renal failure. It is a natural progression in glomerular disease. But they observed reversal of epidemiology. They observed first fall in GFR, raising serum creatinine at their age after the age of 9 years. And albuminuria was reported later after the 16 year of follow-up. Early progression to renal injury was observed among patients with ipsilateral congenital anomaly of kidney urinary tract in comparison to patients without congenital anomaly of kidney urinary tract. So this study gave two important clues. First, if congenital solitary kidney patients have associated congenital anomaly of kidney urinary tract, then this kidney is not going to develop, or it will acquire small size. And second most important thing, they observed the prevalence of CKD. They compared congenital versus acquired. The prevalence of CKD was more in acquired solitary kidney patient in comparison to congenital solitary kidney patient, 4% versus 9%. So in the scenario of congenital solitary kidney, children who have no compensatory enlargement of kidney side and or have ipsilateral congenital anomaly of kidney urinary tract, they are at risk of decline in GFR and progressing of CKD. So what is the clinical application? If a patient or child having congenital solitary kidney have normal size or enlarged kidney, then it is okay. If size is small, then it is not okay. So congenital solitary kidney patient with ipsilateral congenital anomaly of kidney urinary tract, they are risk of declining GFR and progression of CKD. While children who have ipsilateral absence of pocket, they have compensatory enlargement of kidney size and are at lower risk of GFR decline. Role of genetic and environmental factor. The mutations of more than 40 monogenic genes are responsible for the congenital anomaly of kidney urinary tract. 10% of cases have familial aggregation with incomplete penetrance and predominantly autosomal inheritance. However, X-linked and autosomal recessive pattern have also been reported. The other important thing, the uncontrolled gestational diabetic mellitus in pregnancy and use of drugs like aminoglycosides, anti-epileptic, ACE inhibitors and dexamethasone, they can disturb renal development in antenatal period. And out of the nephrotoxic drugs, NSAIDs and aminoglycosides are the most common drugs that can disturb the nephrogenesis during antenatal period. The management of congenital solitary kidney, a USG Doppler can differentiate between congenital solitary kidney and medullary cystic dysplastic kidney during gestation, because there will be no blood flow to the medullary cystic dysplastic kidney. And further, this medullary cystic dysplastic kidney, which looks like normal kidney, will undetectable after 29th week of gestation. And we can confirm it after the childbirth by the DMSA scan. The diagnosis of vesicular total reflex in child by contrast wording cystoscopy we can get. Genetic analysis is recommended for congenital solitary kidney patients having extrarenal malformations to diagnose any possible syndrome. The management of congenital solitary kidney, the recommendations are that children should be followed till adulthood. Ultrasonography should be done yearly up to 3 years, then every 5 years. In girls, the abdominopelvic ultrasonographic scan should be performed between thallards and menards to diagnose the Mullerian duct derived structure anomalies of fallopian tube, uterus, vagina, cervix. The proteinuria assessment should be performed yearly. BP measurement is recommended yearly after the age of 3 years. eGFR, we can calculate easily by the revised Schwartz equation GFR. The recommendation is the GFR should be measured annually in medium risk children. So children who don't have compulsory enlargement of kidney, they are considered as medium risk for CKD progression. So in this patient, annually we should calculate the GFR by revised Schwartz equation. 0.413 into height in centimeter divided by serum creatinine. That's all. You can calculate the GFR in children. After 1 year of age, the RAS inhibitors, renin-angiotensin-aldosterone system inhibitors should be used to control the blood pressure and treat the proteinuria in children. Dehydration nephrotoxic drugs should be avoided for children having solitary kidney. The recommended protein and salt intake should match dietary recommendations of children of same age and size group. Excessive protein and salt intake should be avoided. And there is no restriction on participation in sports. But children and their parents must be aware of the risk of collision injury that may cause blunt kidney trauma because they have single kidney. Acquired cirrhotic kidney. Acquired cirrhotic kidney is found after unilateral radical nephrectomy. Nephrectomy due to donation of one kidney among living kidney donors. Nephrectomy after kidney tumors. Nephrectomy after renal trauma. Nephrectomy after severe and myxomatous pyelonephritis. And after unilateral nephrectomy, the absolute risk of developing end-stage renal disease is low, but the relative risk of developing end-stage renal disease is 3 to 5 times higher. In nephrology, end-stage renal disease, we say when in a patient with chronic kidney disease, the GFR falls below the 15 ml per minute persistently for 3 months. Then we say then it is end-stage renal disease. Later on, sooner patient will go on renal replacement, dialysis or transplant. Pathophysiological alteration acquired cirrhotic kidney. In a healthy kidney donor age less than 60 years, compensatory increase in GFR is up to 65 to 70% of pre-donation GFR. Once a patient donates his or her kidney, the GFR increases. After the 1 week of donation, GFR starts increasing and it can increase up to 65 to 70% of pre-donation GFR. Or changes are in renal hemodynamics and nephron structure. Activation of several pathways lead to compensatory glomerular hypertrophy and CKD progression. There is increased glomerular ultrafiltration coefficient, increased blood flow, renal blood flow, that leads to the increase in the single nephron GFR, and ultimately glomerular hyperfiltration hypertrophy, rather than intraglomerular hypertension. So the glomerular hyperfiltration of the acquired cirrhotic kidney is due to the increased renal blood flow and increased glomerular ultrafiltration coefficient. But glomerular hyperfiltration of diabetic kidney disease is due to the rare intraglomerular hypertension, that is due to the glomerular hydraulic pressure gradient. So both are different. This is the difference between the pathophysiology of diabetic kidney disease and acquired cirrhotic kidney disease. Glomerular hyperfiltration mechanism. Patients of chronic kidney disease with 2 kidneys have different pathogenesis in comparison to kidney donors. Glomerulonephritis and genetic predispositions may contribute to the faster CKD progression in living kidney donors. The outcomes of acquired cirrhotic kidney. Boden et al. Studied the patient age group between 18 to 56 years who had undergone unilateral nephrectomy in their childhood. This is a very important study. They studied the children and they did follow-up for more than 25 years. The children underwent nephrectomy in their childhood. They reported that majority of the patients maintained kidney function. They did nice after nephrectomy. However, patients who were followed more than 25 years, they showed an increase in the proteinuria, high blood pressure, and high incidence of renal failure. However, living kidney donors undergo extensive screening before donation. The person who donates the kidney to anyone, his relative, he undergoes extensive investigation so that they could have completely better healthy kidney after donation, and that might be the reason for good prognosis in living kidney donors. The long-term outcomes of acquired cirrhotic kidney depends on, before donation we can predict what will be the outcome of that acquired cirrhotic kidney. Age at the onset of cirrhotic kidney, usually young or middle-aged patients donate the kidney. Residual nephron mass immediately post-nephrectomy. The GFR of the both kidneys separately. Duration of cirrhotic kidney and associated comorbidity. Whether the patient is having diabetes, hypertension, obesity, renal stone disease, all these are factors. Malignancy is common in elderly age, so unilateral nephrectomy in elderly group will cause more problem as compared to others due to the comorbid conditions. This was a study published in Kidney Medicine in 2023. Risk factors for developing low GFR and albuminuria in living kidney donors. This study included approximately 590 patients. They included from 2001 to 2017, and they, over a median period of follow-up 8.6 years. After the 8.6 years of follow-up, they observed that 8% patients develop albuminuria or decrease in GFR. Lam et al. Compared 604 living kidney donor patients with more than 2000 controls and observed that from 6 weeks onward till 7 years of median follow-up, increase in the eGFR is 0.35 ml per minute per year in kidney donor. But in controls, there was a significant decrease in the GFR, 0.85 ml per minute per year. So, this increase was due to hyperfiltration, glomerular hyperfiltration in kidney donors, but decrease was due to the aging kidney. Age-related glomerulosclerosis says that after the age of 30, there is a decrease in the GFR 1 ml per minute per year due to the age-related glomerulosclerosis. That is the natural fall in GFR. Garg et al. Compared 1,278 living donors with more than 6,000 controls, and after the 6-year follow-up period, they observed the hypertension was prevalent in living donors. Approximately 16.3% of donors had hypertension after a follow-up period of 6 years, while in controls it was 11.9%. This was another 33-year follow-up data from the US Scientific Registry of Transplant. It showed that 0.4% patient developed end-stage renal disease during 33-year follow-up. In general population, the prevalence of ESRD end-stage renal disease approximately 0.22%. 0.2% in general population. And post-transplant patient 33-year follow-up data says that prevalence was 0.4%. Although there is reported evidence of the survival of living kidney donors for more than 50 years, it is on record. However, University of Minnesota series and Canadian series, they reported mean interval of 27 years of survival from condition to development of ESRD. This was another important study. It was an 11-year follow-up study of more than 1.25 lakhs living kidney donors. This study showed that in first 10 years after kidney donation, glomerulonephritis was the leading cause of end-stage renal disease, and after 10 years, as in general population, diabetes mellitus and hypertension were the common causes of end-stage renal disease. And major cause of, and this study point out that major cause of end-stage renal disease were environmental related renal disease or immunological factor rather than hyperfiltration induced FSGS and CKD. So this environmental related renal disease is now great threat. What do you mean by environmental related renal disease? Means soil pollution by the industrial waste and farmers, pesticides, insecticides, air pollution, soil pollution mainly, the heavy metals like lead, mercury, chromium. These metals gets impregnated inside the soil and they can go to the fish and vegetables. This is new threat for the development of CKD. There are 3 states in India there is more prevalence of CKD: Goa, Odisha, Andhra Pradesh. Industrial areas there is more prevalence of CKD. Risk factor for CKD onset in living kidney donor at the time of kidney donation. So what could be the risk factor at the time of donation of the kidney? Smoking, high BMI, older age, hyperlipidemia, high blood pressure, African American individuals and APOL1 gene type were associated with development of proteinuria later on and development of CKD later on in living kidney donors. Pregnancies after donation are considered to be at high risk. Sometimes, out of emotional touch, young females donate the kidney to their father or brother or sister. But there is a definite risk. The risk for development of hypertension, preeclampsia are more than expected in pregnancies among living kidney donors. And this risk of preeclampsia is equivalent to that observed with high blood BMI, gestational diabetes mellitus and chronic hypertension. So it is not safe to donate the kidney by the young girls. They can develop preeclampsia in their pregnancy. What are the factors indicating early onset chronic kidney disease among living kidney donors? What the indicators we can use in general population also? Young et al. Compared living kidney donors with the non-donor controls. They observed that increased level of serum intact fibroblasts for factor 23, increased intratubular fractional excretion of inorganic phosphorus, low level of serum calcium, low level of serum phosphorus. They were associated with early onset of CKD among living kidney donors. Management of acquired cirrhotic kidney. As we know, glomerular hyperfiltration develops after 1 week of the nephrectomy, post-nephrectomy, and it can continue for more than 10 years. Although measured GFR is more accurate, but the creatinine-based eGFR equations are preferred for the follow-up of the kidney function living kidney donors. Measured GFR means they are the exogenous filtration marker, radioisotope, DTPS scan. They give the better measurement of GFR, known as measured GFR, than the creatinine-based equation, MDRD, CKD API equations. But conventionally, they are preferred creatine-based GFR equations are preferred. DASH diet, dietary approach to stop hypertension, we all know, include fruits, vegetables, legumes, whole grains, low animal diet, low processed food. High protein diet in patients having solitary kidney, whether congenital or acquired, should be avoided. Heavy protein diet, heavy exercise should be avoided. Because high protein diet causes the afferent arterial dilatation, which leads to intraglomerular hypertension and proteinuria in long term. Avoid dietary protein intake more than 1 gram per kg per day for healthy kidney donors. Although professional bodybuilders and athletes are exception to this, the recommended dietary sodium intake should be less than 4 gram per day. Recommended BMI is less than 30 gram per meter square. Because it has been observed that obese donor has 1.86 times higher risk to develop ESRD during a 20-year follow-up. Avoid smoking. Smoking is independent risk factor for progression of CKD in normal population and also in patients having solitary kidney. Avoid smoking, nephrotoxic drugs, and maintain hydration. Because low fluid intake causes the increased vasopressin secretion, that leads to the increased albumin excretion in urine. For patients having GFR more than 60 ml per minute, in case of solitary kidney patients, the recommended fluid intake is more than 2.5 liter per day. Maintain the blood pressure less than 130/80, and RAS blockers are the proven neuroprotection in both congenital solitary kidney after the age of 1 year and acquired solitary kidney. They should be used because the RAS blocker dilate the efferent arteriole more than afferent arteriole, and they decrease the intraglomerular hypertension, they decrease the proteinuria. Now this is the comparison, this is very important. Congenital versus acquired solitary kidney. Nephrogenesis, they have some minimal potential to form new nephrons, but in acquired solitary kidney there is no potential for some new nephrons. The glomerular hyperfiltration, congenital solitary kidney susceptible for the glomerular hyperfiltration, but acquired solitary kidney have more pronounced glomerular hyperfiltration more than solitary kidney. The GFR, as I already told that higher the number of GFR, higher the number of nephrons, higher the GFR. Because the congenital solitary kidney have higher number of nephrons, so GFR will be higher in comparison to the acquired solitary kidney. CKD risk at risk, both the kidney types, congenital and acquired, are at risk of CKD development, but acquired solitary kidney have higher risk for the CKD development in comparison to congenital solitary kidney. The risk factor for CKD development in congenital solitary kidney, ipsilateral congenital anomaly of renal tract, recurrent UTI, prematurity, low birth weight, small size kidney, low socioeconomic status, use of nephrotoxic drugs during antenatal period. These are the risk factors for the CKD development in congenital solitary kidney. Whenever a patient encounter you having congenital solitary kidney, you should keep in your mind all these possibilities. You should think on these lines. Risk factor for CKD development in acquired solitary kidney: higher age, diabetes, cardiovascular disease, high serum uric acid, metabolic syndrome, unilateral nephrectomy after renal tuberculosis, and nephrotoxic drugs. Now we can summarize. The solitary kidney patients have reduced number of nephrons and are at risk of hyperfiltration into proteinuria and CKD progression. And compensatory enlargement of congenital solitary kidney begins at 20 weeks of gestation, continued till adolescence. Children with congenital solitary kidney should be followed till adulthood. The children without compensatory enlargement of kidney and or with ischemic congenital anomaly of kidney tract are at risk of decreasing the GFR in CKD. Genetic factors, uncontrolled gestational diabetes, drugs can disturb the nephrogenesis during antenatal period, leading to congenital solitary kidney. Acquired solitary kidney have lower GFR and higher risk for development of CKD compared to congenital solitary kidney. In living kidney donors, glomerular hyperfiltration hypertrophy occurs due to the increased glomerular ultrafiltration coefficient and increased blood flow, while intraglomerular hypertension is a reason for the progression of CKD and glomerular disease in general population. There are increased risk of hypertension, preeclampsia and pregnancy among living kidney donors of childbearing age group. A high protein diet and high salt intake may further aggravate the glomerular hyperfiltration and may further decrease the GFR. Nephrotoxic drugs and dehydration should be avoided in solitary kidney patients, and after 1 year of age, RAS inhibitors should be used to control the blood pressure and treat the proteinuria. Avoidance of smoking, DASH diet, control of diabetes, obesity, and healthy lifestyle are the cornerstone for the management of acquired solitary kidney patients. The take-home message is that clinicians should be aware of the embryology, evolution, and complications of solitary kidney that occur over the time. The fate and outcome of solitary kidney is not always benign. There is always possibility that congenital solitary kidney patient might have an association with Wolfram duct-derived structure anomaly in male and Mullerian duct-derived structure anomaly in female. The individual with congenital solitary kidney with ischemic congenital anomaly kidney disease and or without compensatory enlargement may express proteinuria, hypertension, and decrease in GFR in later on in their future life. While individuals with acquired solitary kidney, they may have good long-term outcomes, but are at higher risk of developing CKD and ESRD in comparison to congenital solitary kidney. Thank you.
कहते हैं कि मंजिल के आगे मंजिल तलाश करो, मिल जाएगा दरिया तो समुद्र तलाश करो. Now I request Dr. Alok Sharma sir, cardiologist, Medical College Jhansi, to kindly present a bouquet to our respective chairperson Dr. N.S. Singer Sahab and do a honor to him. Now house is open for discussion.
Kidney, and how many are there to achieve the how many should be there to achieve the healthy GFR? Sir, it would be nice if you talk over the speaker.
So the normal nephron number is 0.6 to 1.4 million in each kidney.
Sir, as per the age, sir, congenitally solitary kidney, it's differ, and the person who donates the kidney or the acquired solitary kidney post nephrectomy, it differs. So please elaborate this.
So first, the number of nephrons. Number of nephrons in acquired solitary kidney, that is after donation of kidney, are 50% only. There is no increase in the number of nephrons. But in congenital solitary kidney, there are nephrons are 75% in comparison to two kidney.
Sir, there are n number of studies. Even the nephrologist says, there are so many friends of mine, those who are nephrologists. They say if you donate the kidney, you live longer. Why so?
I told in this slide that relative risk is more. Relative risk is less, absolute risk is more. If donor is having no hypertension, no diabetes, then
sir, one healthy donor 50. At the age of 50 years, and the one congenital is solitary kidney. Forget solitary kidney. One healthy donor at the age of 50 years already having GFR of somewhere around 70. If she or he donates the kidney, they say the person who donates the kidney live longer, and there are studies over the internet also. So how do you explain that, and what is the meaning of that?
So please repeat the question. Your donor having how much GFR?
75.
It is not like that.
So donor will not have 75 GFR, no? When will you, before the kidney transplant, GTP scale of donor is done?
Because donor, all the investigation of donor is done. If he is diabetic
treatment of diabetes.
Sir, healthy donor.
Healthy donor, sir. Healthy donor will have.
Yeah, all the investigations will be done and he will be treated. Some are marginal donors, some are healthy donors. So they live long. But actual risk is higher. Because proteinuria is higher, hypertension is higher in living donor.
No sir, it is not like that. If your actual life expectancy is 10 years, after that, after the kidney donation, they say it increases.
Hey, who says?
Sir, there are n number of trials.
Tell me trials. There are.
बढ़ कैसे जाएगी यार? तुमको सर बढ़ेगी कैसे? कर सकती है, बढ़ेगी तो आएगी.
Sir, I will post tomorrow all the things in the API group.
This may be a political slogan. Donate करने से बढ़ जाएगी. मेरे ख्याल से बढ़ेगी अच्छा कैसे बढ़ेगी?
Sir, actually, if the donor is healthy with no comorbidities, there is theory, not theory, there is practicality. The nephron number increases, hypertrophy of the nephron. हाँ, EGFR increase हो जाता है सर. तो सर EGFR increase हो रहा है तो a single kidney is sufficient to maintain the donor.
Sir, this is only slogan to promote donation. It is not that life expectancy of living donor is higher than the general public.
ऐसा नहीं है.
So, glomerular hyperfiltration will lead to the progressive focal segmental glomerular sclerosis. And there is data on record up to 50 years donors are safe. Up to 50 years. But
Okay sir.
glomerular hyperfiltration will cause the kidney injury in the form of focal glomerular sclerosis.
There is a question. In all the acquired solitary kidney, should we give ACE inhibitor or ARB?
Yeah, sir.
What is the role of SGLT2 and finerenone in them?
Sir, finerenone is a separate topic. There are 3 landmark trials: Figaro, Fidelio, and Fidelity. Fidelio for renal protection, Figaro for cardiac protection, and Fidelity pooled analysis from both the trials. Finerenone is a very good drug, wonderful drug. It has pleiotropic effect. It will prevent the fibrosis. It will improve the GFR. It will decrease the proteinuria. Finerenone.
One patient per diabetic.
Till date, studies are in diabetes, but now studies are going on.
In CKD?
Non-diabetic also.
Non-diabetic.
But results have not come.
Results have not come.
Sir,
Fit India trial.
Sir,
And what is the role of SGLT2 inhibitor?
sir,
So, as well as inhibitor,
ये अगर CKD होगा तो दोगे.
so there are 2 trials: DAPA CKD trial, AMPA CKD trial. DAPA CKD trial said that
यदि डायबिटीज में प्रोटीनुरिया है देंगे कि नहीं देंगे?
sir,
नहीं उसकी
Actually, DAPA CKD and AMPA CKD are beyond your scope of this presentation. Sir is like, sir क्या कर रहे हैं? Sir, मेरा question एक बहुत genuine है.
it is not beyond the scope because proteinuria is there in single kidney, so
Yes.
we have to treat it.
नहीं the question which was raised by Dr. Alok Sharma, his question is very valid. कोई क्या है after giving kidney, the patient's life he may live longer because reason is very simple. Why he will live longer? The answer is very simple. Because जो जिससे आप डोनेट कराते हैं किडनी उसका आप कंप्लीट चेकअप करते हैं.
True sir, true.
Complete.
और उसको आप प्रॉपर डाइट बताते हैं, आपको कैसी लाइफ जीनी है, क्या करनी है, तो लिव लॉन्गर करता है.
Naturally, but उसकी लाइफ लेकिन उसका
रिस्क बिहेवियर ही खत्म हो जाता है.
एक क्वेश्चन मेरा है, उसकी लाइफ बढ़ जाती है. ये कहना तो ठीक है, लेकिन इसकी वजह से बढ़ जाती है नहीं.
सर, आई हैव वन ब्यूटीफुल क्वेश्चन टू यू. आपकी स्लाइड में एक चीज थी कि आफ्टर 1 ईयर इन द पेशेंट ऑफ कंजेनिटल सोलिटरी किडनी 1 ईयर के बाद में आपने ARB ACE इनहिबिटर का रोल बताया था अभी अपनी स्लाइड में. तो सर, जैसे मान के चलिए मेरे पास कोई भी बच्चा आता है, इफ एनी चाइल्ड कम टू मी फॉर एनी अदर रीजन, और मैं उसका USG करता हूँ, मुझे सोलिटरी किडनी मिलती है, तो मेरा पहला क्वेश्चन ये है, डू आई नीड टू फाइंड आउट अनदर किडनी समवेयर एल्स कहीं नीचे ऊपर तो नहीं है, उसके क्या तरीके हैं? पहली चीज और दूसरा ये है, अगर मुझे नहीं मिलती है या फिर वो बिल्कुल एजेनेसिस है, सॉलिटरी किडनी ही है, तो सर मुझे ACRB कब से शुरू करना है और कब तक देना है, या प्लीज बताएं।
सर ACRB आपको तभी देना है, देयर इज प्रोटीन यूरिया और हाइपरटेंशन।
सर तो सर मुझे प्रोटीन यूरिया के लिए वेट करना होगा?
नहीं, you have to follow annually. You have to follow.
Same question मेरा है.
And besides that, you should keep in your mind that is there any possibility of having congenital anomaly if you are dealing with congenital solitary kidney patient?
I have got two patients, two kids. One presented at the age of 17 years and one was at the age of somewhere around 11-12 years. They had solitary kidney. With one, when I did the scan, one kidney was found out with a remnant of बिल्कुल एकदम छोटा किडनी, बिल्कुल नीचे था पेल्विस में, तो वो तो एकदम मतलब अंडर डेवलप्ड किडनी था, और सेकंड जो था वो नहीं था। तो सर ऐसे पेशेंट्स को क्या उनका प्रोग्नोसिस होता है, क्या करना चाहिए, ACRB चलाना चाहिए या नहीं प्रोफाइलैक्टिकली, इवन इफ दे डोंट हैव प्रोटीनूरिया, और at what age should I expect to have them of proteinuria?
First, you see the kidney side. If there is a compensatory enlargement, then it is okay. Do the urine filtration microscope if there is no proteinuria. Check the blood pressure. There is no blood pressure. No need to start ACRB. But you have to counsel the parents. Avoid nephrotoxic drugs in future. Avoid heavy exercise. Avoid high protein diet. Avoid daily non-veg, etc., etc. And ask the patient if younger, 3 years, 4 years, 5 years.
Sir, how non-veg affect the single kidney?
High protein diet. It will dilate the afferent arterioles.
Sir, is there any amount of non-veg which a patient can take?
More than required. इसकी एज के हिसाब से
एक क्वेश्चन मेरा है.
Sir, actually, sir, there are so many patients who are those who are non-veg dependent. Actually, sir, it may be.
एक क्वेश्चन मेरा है.
सर वो हार्डकोर नॉन वेजिटेरियन हो सकते हैं, तो सर हम ये कह सकते हैं कि आप एक ही एग खाइए, आप एक चिकन बाइट लीजिए। सर थोड़ा सा डाइट का एक वॉल्यूम बताएं जिससे उनकी किडनी पे असर ना पड़े।
1 ग्राम पर किलोग्राम बॉडी वेट प्रोटीन।
1 किलोग्राम बॉडी वेट।
सर 1 ग्राम तोल नहीं सकते ना सर, एक लेमन लैंग्वेज।
एक घंटे में 6-7 ग्राम प्रोटीन होती है।
हाँ सर।
एक कटोरी दाल के अंदर 7 ग्राम प्रोटीन होती है।
बिल्कुल सर।
एक गिलास दूध में 5 ग्राम प्रोटीन होती है। एक रोटी में 2
नहीं सर, चिकन एंड मटन में
एक लास्ट क्वेश्चन, मैं कई यूरोलॉजिस्ट के साथ वर्क करता हूँ।
पनीर में 20 ग्राम
सॉलिटरी किडनी में दे ऑलवेज स्टार्ट दिस ये एंजियोटेंसिन इनहिबिटर्स या रास ब्लॉकेज
ब्लड प्रेशर
irrespective of blood pressure. जितनी भी सॉलिटरी किडनी के पेशेंट हैं, दे स्टार्ट, उनका लॉजिक ये रहता है कि हाइपर फिल्ट्रेशन हो रहा है इसलिए हमें एज इनहिबिटर देना है। तो दे आर राइट और रॉन्ग? पोस्ट सर्जिकल
So they should keep the patient in follow up and regular follow up yearly.
नहीं, अगर हाइपरटेंसिव नहीं है, प्रोटीनूरिया नहीं है, तो भी क्या हमें देना
So
है?
recommendation तो नहीं है।
ठीक है।
तो सर को फॉलो कितने समय पे करना है? साल में एक बार, राइट?
एक स्लाइड थी आपने इंग्लिश में दिया।
नहीं, मैंने देखा है ईयरली फॉलो अप करना है, यूरिन करा के देखना है, RFT करा के देखना है, ये बात सही है।
We have to follow up in adulthood.
हाँ, अब सर एडल्ट हो गए, एडल्ट होने के बाद में कोई दिक्कत नहीं है, एडल्ट तक हमने शुरू नहीं किया, तब भी ईयरली। ओके सर, ओके।
Because one study showed that children after 25 years of age, then they express proteinuria and decrease in the GFR.
27 साल बताया हमने, 27 years
हाँ, वही सर 27 साल के बाद भी फॉलो अप 1 ईयरली करना है या जल्दी करना है?
1 year. 1 year is sufficient.
ओके सर।
So, Dr. Sathi, you are a nice colleague and nice presentation.
Thank you, sir.
And this is a topic which is rarely discussed in clinical meetings. And you have covered embryology to physiology, and embryology is a very difficult subject. We have covered so nicely, and physiology, pathophysiology. 2 points in your slide. One is what do you mean by in CSK? the chances of more CKD in those patients who have CSK with ipsilateral cacut, number one. And what is the role of socio-economic thing on CKD development in CSK? That was in your slide. Socio-economic. Low socio-economic patients of the CSK, they have more chances of CKD.
So they,
Great, sir. Very
Frequent maybe infections and
they all take the over-counter pills.
repeated
Dehydration.
infections, coronavirus, common children. And what is the role of this thing? What do you mean by CSK with
So congenital anomaly of kidney urinary tract.
of the same side or opposite side?
So opposite side to kidney है ही नहीं, same side.
Same side. Acha, okay. If they have associated cacut,
क्या कहना है?
then they have
They are at higher risk for.
higher risk. Yes, yes.
सर मेरा एक क्वेश्चन और है सर आपने कहा था कि एनसेड अवॉइड करना चाहिए सर मेरे पेशेंट को 27 इयर्स तक कोई प्रोटीनूरिया नहीं है और एंड एवरीथिंग इज फाइन बट 27 इयर्स तक वो चोट खा सकता है, उसकी हड्डी टूट सकती है, उसकी कमर में चोट आ सकती है, वो क्रिकेट खेल रहा हो या फुटबॉल खेल रहा हो, कुछ भी हो सकता है। तो सर मैं उसका पेन को कैसे रिलीव करूँगा ये बताइए। सर ट्रेमाडोल से नहीं रिलीव होता है चोट का पेन।
किडनी गार्ड हो पाएगा, किडनी गार्ड,
सर पैरासीटामोल ट्रेमाडोल जो है ना सर ये देखने में अच्छी लगती है लेकिन होता नहीं है।
ये बताओ ना सॉलिटरी किडनी में अगर सीकेडी का एविडेंस नहीं है तो फिर एनेस्थेसिया देने में क्या दिक्कत है?
थोड़ी बहुत देने में
अगर नहीं सीकेडी का एविडेंस नहीं है, नो प्रोटीनिया, नो हाइपरटेंशन एंड ग्लोबल देयर इज हाइपरट्रॉफी एंड देयर इज इक्विलिब्रियम नॉर्मल, सीएम डिफरेंशिएशन इज नॉर्मल, तो क्या दिक्कत है?
ग्रेट आंसर। मेरा भी यही कहना था कि अगर सर प्रोटीनूरिया नहीं है नहीं मैं सर ये कह रहा था कि सर अगर सिंगल सॉलिटरी किडनी है वहां पे किडनी हाइपरट्रॉफी हो रखी है।
Sir, we already discussed that solitary kidney have lesser number of nephrons.
75%.
Solitary kidney at risk. It is well documented.
Calculate the nephron.
We can calculate the GFR. Sir, nephron के लिए फिर आपको nephrectomy, rat study, pig study करना पड़ेगा. We can calculate the GFR with the help of serum creatinine.
नहीं एक पेशेंट जिसकी नेफ्रेक्टोमी हो चुकी है, सिंगल किडनी है, वो हमेशा हाई रिस्क पे रहेगा।
सर ये सीएसके की बात करिए।
ओके सीएसके की बात, वो किडनी तो है ना, सिंगल किडनी है और उसका जो जीएफआर जिसके नेफ्रॉन्स हैं वो इंस्टेड ऑफ 50% 75% है, लेकिन सर 100% तो नहीं है ना, 100% तो नहीं है, 75% है। ऐसे में आपको केयर तो लेनी पड़ेगी उसकी, एनाल्जेसिक्स या नेफ्रोटॉक्सिक ड्रग्स आपको ध्यान देते हुए देना पड़ेगा। यू कांट ट्रीट हिम लाइक ए नॉर्मल, you have to treat an special. So you can't give analgesics or nephrotoxic drugs left and right as you give in other.
सर अगर एनाल्जेसिक का 1 या 2 डोज या मान लिए 2-3 दिन हमने दे दिया पेशेंट को और उसको स्टॉप कर दिया तो क्या उसका असर रहेगा? तो ये ना नहीं, तो हमें लगता है अगर किडनी फंक्शन प्रॉपर है तो आप उसको शॉर्ट ड्यूरेशन के लिए एनाल्जेसिक दे सकते हैं, अब रिगार्डलेस कि आप किडनी फंक्शन वॉच करते रहे।
But sir, AIN, acute interstitial nephritis can be caused by single dose of anesthesia.
Yes, agree.
But that can happen in any patient.
Any.
वो तो कहीं भी हो सकता है। What is the harm in giving such patients?
वो तो कहीं भी हो सकता है।
Have everything okay with the solitary kidney. उसका फिर क्या हार्म है?
उसका आंसर एक है, लीगल प्रॉब्लम है उसका। सिंगल पेशेंट है आपके पास, सिंगल किडनी पेशेंट है, लीगल पेशेंट है, जनरल पेशेंट है, आपने उसमें सिंगल एनालिसिस यूज किया, सिंगल टैबलेट 2 टैबलेट कोई बात नहीं है, यदि डायबिटिक है यू हैव टू बी केयरफुल, बट यदि पेशेंट यदि सिंगल किडनी वाला है, डायबिटिक भी नहीं है, फिर भी आप यूज कर रहे हैं तो आपको बताना पड़ेगा पेशेंट को, लीगल उसकी इन्फॉर्मेशन, उसकी लीगल प्रॉब्लम है उसके अंदर, वो पेशेंट जा सकता है कि साहब मेरे सिंगल किडनी थी, डॉक्टर ने मुझे दवाई दे दी, मैं एक्यूट किडनी में चला गया, तो लीगल प्रॉब्लम है उसकी।
सर वो पेशेंट के लिए आई एम टॉकिंग अबाउट सीएसके।
हाँ,
सीएसके का पेशेंट होता है यंग।
हाँ, ठीक है।
यंग पेशेंट फुटबॉल खेल रहा है, उसका पैर टूट गया। पैर टूटने में ऑर्थोपेडिशियन ने बोला कि आपको NSAID 5 दिन खाना ही पड़ेगा, तो सर क्या करना पड़ेगा?
ट्रामाडोल और डबल डोज ऑफ पैरासिटामोल,
हाइड्रेशन मेंटेन करो, हाइड्रेशन मेंटेन करो और दबा दो।
सर आपने बोला पॉल्यूशन के बारे में बात कर रहे थे
और दबा देखिए।
पॉल्यूशन के बारे में बात कर रहे थे, पॉल्यूशन में इफेक्ट है। तो कौन से पोल्यूशन जो ज़्यादा इफेक्ट कर सकते हैं, और जैसे आपने कहा कि औद्योगिक बन रहा है, जैसे बीड़ा बन रहा है, उससे क्या फर्क पड़ेगा?
बीड़ा से किडनी खराब हो जाएगी।
बीड़ा में जमीन ले लो।
बीड़ा से मतलब किडनी खराब।
सर सोयल पोल्यूशन ना
सर अगर
आप बिंदास जवाब दीजिए, परेशान नहीं होइए, आप दीजिए।
नहीं ये तो बिंदास। सर हाइपरटेंसिव डायबिटिक, कंट्रोल्ड हाइपरटेंसिव डायबिटिक with normal GFR can donate the kidney.
90% cannot.
Irrespective of age. Diabetic, hypertensive controlled with normal GFR, with normal even function.
ये तो कॉन्ट्राडिक्शन है। ये नहीं कॉन्ट्राडिक्शन है, ये नहीं कर सकते।
नहीं, these are classified as marginal donors.
हाइपरटेंसिव इसके अलावा
Marginal
रिलेटिव कंटेंट सर है, रिलेटिव।
So there will be more progression of chronic kidney disease once the diabetic patient has single kidney.
Sir, come to the antenatal period. You shown in one slide that if birth taken place in less than 30 weeks of pregnancy, the number of nephrons is less as compared to normal age. So what are the other risks of having lesser neuron in nephrons in neonates? What should be taken precaution in pregnant women?
So in literature these are mentioned any embryonic insult that can lead to failure of formation of ureteric bud. Ureteric bud is formed from the nephrogenic cord.
So one is GNSCA.
So
Okay.
that can develop. Genetic reason might be there. Among drugs, NSAIDs, anti-epileptic, aminoglycosides, these are the main culprits.
Any other things?
So genetic factors, radiation.
So many patients has come to us with pregnancy-induced hypertension, pregnancy-induced diabetes.
So gestation diabetes, clear-cut respect.
Yes.
Gestation diabetes.
मेरी सारी practical problem है. I have 2 grandchildren, right? They took birth at the age of 28 or 29th week. हाँ ठीक है, 29th में उनकी जन्म हुआ, दोनों आज की डेट में प्रोफेशनल कॉलेजेस में पढ़ रहे हैं. They are doing exceedingly well. They are toppers. ठीक है नहीं तो अब मुझे उनके जन्म 29th वीक पे हुआ, ठीक है, उनकी केयर बहुत ऑनलाइन इंस्टीट्यूट में बहुत केयर हुई, 3-4 महीने वहाँ रहना पड़ा, सब हुआ. बट यू सेड कि जो 28 वीक से पहले और 36 वीक्स पहले जिनकी प्रोग्रेशन नेफ्रॉन का जो लेवल है 28 वीक से पहले तो बहुत ही कम है, 36 वीक से पूरा नॉर्मल नहीं आया है. व्हाट शुड आई एक्सपेक्ट इन दीज 2 किड्स at now, because their kidney now their biochemical parameters are absolutely normal. They go for examination for every year.
Kidney size क्या है? Kidney
size normal. Kidney size आज की डेट में normal है.
So literature says that prematurity is risk factor for future development of CKD or FSGS.
अभी दोनों बताया.
But it is not necessary.
हाँ. Risk factor. नहीं उनको बच्चों को ये भी बताना पड़ेगा प्रीटर्म वाले हैं, चांसेस ऑफ प्रॉब्लम आर देयर, लेकिन जब दोनों की किडनी नॉर्मल है तो मेरे ख्याल से दे शुड बिहेव लाइक नॉर्मल. अब तो हाँ
सर इसमें लिटरेचर सेज कि since there are lesser number of nephrons, so they are more prone for hypertension, CKD, diabetes and all other non-communicable diseases. जब nephrons कम है तो hypertension किसी भी स्टेज में लाइफ के डेवलप कर सकते हैं. तो every 2 year में
आज की डेट में कैसे पता लगेगा?
नहीं सर, आज की डेट में फॉलो अप करना पड़ेगा सर.
अगर चल ही रहा है
हाँ 2 ईयरली फॉलो अप कर रहे हैं.
नेफ्रॉन नंबर देखो तो रीनल साइड भी कम होगा.
सर मेरा एक और क्वेश्चन है.
बढ़िया है.
नहीं
बिल्कुल ठीक है.
सर
तो फिर क्यों कम हो गया नंबर?
सर रीनल साइज.
तुम यार ये बताओ.
सर मेरा एक और क्वेश्चन है.
सर क्वेश्चन पहले क्वेश्चन सर पूछिए.
नहीं मेरा क्वेश्चन तो पूरा आंसर कर दे.
नहीं मैंने अगर देखिए किडनी चाहता
सर को माइक दो सर.
premature patients are already risk for hypertension, proteinuria, and CKD, FSGS. लेकिन अब ये एडल्टहुड उनका आ गया, एडल्ट है उनका, एडल्ट हो गए और एकोजेनिटी नॉर्मल है, रीनल साइज नॉर्मल है, प्रोटीनुरिया नहीं है, तो नाउ जो बाकी जो कंपैरेटिव रिस्क है पॉपुलेशन की वो रहेगी।
सर मेरा
लेकिन इन्होंने ऐसा नहीं बताया।
सर मेरा
सबसे
सर मेरा कहना डिफरेंट है कि आफ्टर 40 इयर्स ऑफ एज वो हमें वॉच करना पड़ेगा सर, उस समय एवरी ईयरली और 2 ईयरली फॉलो करना पड़ेगा।
क्योंकि मैं बच्चों को ये जरूर बताता रहता हूँ कि ओबेसिटी का इंसिडेंस भी ज़्यादा है, जो प्रीमेच्योर इंसिडेंस बहुत ज़्यादा है, सीकडी का इंसिडेंस बहुत ज़्यादा है, इन सब चीज़ों का इंसिडेंस ज़्यादा है, इसलिए आई ऑलवेज कीप इट टेलिंग ना। बताओ
सर मेरा एक और क्वेश्चन है आपसे, सेंगर सर से और साथी सर से।
सर एक चीज है सर,
सेंगर सर से भी क्वेश्चन है और साथी सर से भी। सर जैसे CS के है कंजेनिटली सॉलिटरी किडनी, बच्चा बड़ा हो गया, कोई सिम्टम नहीं है, कुछ नहीं है, बच्चा कॉलेज में भी जाएगा, एंजॉय भी करेगा, पानी भी पिएगा, दारू भी पिएगा, तो सर जैसे पता चल गया पहले, तो सर ऐसे पेशेंट्स को सर फ्लूइड रेस्ट्रिक्शन, बियर या वाइन रेस्ट्रिक्शन, या फिर क्या करना चाहिए या नहीं करना चाहिए, ये बताइए।
तीन सवाल पूछे, इनका सवाल है should they be restricted taking beer, wine and fluid?
Sir, any amount of alcohol is not recommended, it's injurious for anybody.
Any amount?
Sir, new studies are...
नहीं सर, ऐसा तो नहीं है सर, ये स्टडीज में भी नहीं है, एनी अमाउंट ऑफ अल्कोहल मत बोलिए सर प्लीज। सर इतना तो मैं भी जानता हूँ सर।
रिकमेंडेशन
वही सर, तो नहीं, आई वुड लाइक टू इनवाइट सेंगर सर फॉर द टॉक राइट नाउ।
It is not recommended.
सर आप alcohol never recommended.
Regarding alcohol, as far as and obviously alcoholism is not good. If you think social alcohol intake 3 packs per week, I think they are permissive in, जहाँ तक हम लोग स्टडी करते हैं, अभी कोई नई स्टडी आगे मुझे पता नहीं।
2 packs
per week.
Actually the term which is used,
not only about alcohol, it is daily fluid intake. मतलब पानी कितना पीना है और अल्कोहल कितना लेना है।
GFR is
सर सॉल्ट एंड प्रोटीन,
सॉल्ट का है।
हाँ सर चारों बताइए।
सॉल्ट का रिस्ट्रिक्शन है नंबर 1, फ्लूइड का रिस्ट्रिक्शन गाइडेड बाय थर्स्ट, कोई जरूरत नहीं है।
GFR is more than 60.
नो फ्लूइड रिस्ट्रिक्शन डिसाइडेड बाय थर्स्ट। अगर हार्ट फेलियर नहीं है
सर, ये तो पक्की बात है, अगर 15 साल का बच्चा है या 17 साल का बच्चा है सॉलिटरी किडनी का, और अगर वो कॉलेज में गया है, तो ये तो कंफर्म है कि उसका GFR मोर देन 60 होगा। एसिम्प्टोमेटिक अगर है वो,
देखना तो पड़ेगा।
नहीं होगा सर, मतलब 99% तो होगा। 1%
देखो जो गाइडलाइन कहती है मॉडरेशन, एंड द टर्म मॉडरेशन इज वेरी ड्यूबियस।
सर मुझे लगता है सॉलिटरी किडनी पे सबको बोलना चाहिए, हम लोग थोड़े छोटे हैं।
Smoking cessation and alcohol in moderation, this is the standard teaching which we have.
Alcohol भी
Should not be taken.
must not be taken.
रिकमेंडेशन कोई नहीं है।
सर मतलब कितना फ्रीली वो जिंदगी जी सकता है। यार मुझे 2 बियर पीनी है, तो 2 बियर पी पाएगा कि नहीं?
I don't recommend alcohol, any from beer or alcohol.
मैं ये पूछना चाहता हूँ, आपने जो सेंटेंस बोला अभी जो बोला, you do not recommend any amount of alcohol in CSK. In CSK की बात हो रही है? Anybody.
So I think that we have a wonderful discussion.
You said very clearly that you don't recommend any alcohol in CSK or in life.
Sir, alcohol is not injurious to kidney. It is injurious to liver and malignancy. Recent data showed that the risk of malignancy by alcohol.
We are talking about CSK. We are talking about CSK.
Alcohol itself is not injurious to the kidney.
ठीक है, नहीं तो पेशेंट
बताइए सर, मैं ये कह रहा हूँ कि मेरे फ्रेंड का एक बच्चा है, उसको CS कहते हैं। वो सर अब कॉलेज में जाना चाहता है, वो ये चाहता है कि मैं अपनी जिंदगी जी पाऊं, तो क्या मैं उसको ये कह सकता हूँ कि बेटा ये BS पी सकता है?
Let's clap.
या 2 BS पी सकता है?
We had a wonderful discussion. Let's clap and we'll further discussion. In the dinner, if somebody does not fail to register dinner, they come to the breakfast. In the morning we can discuss this topic.
Otherwise, what is the definition of अपनी जिंदगी जीना?
भाई लड़के पूछ रहे हैं, तुमने नेफ्रॉन तो पूछ लिए कितने हैं? पूछ रहा हूँ भैया। तुम्हारा मायोसाइट भी पूछ ली। उसमें कार्डियो में मायोसाइट कितने होते हैं? मायोसाइट बताओ। ये बताओ। ये सवाल रजत का नहीं बताएगा ना। नहीं मेरा और रजत का है। तुम ये बताओ, मायोसाइट नेफ्रॉन पूछ लिए 20 लाख होते हैं, 10 लाख इधर होते हैं, मायोसाइट कितने होते हैं?
नहीं सर, मायोसाइट का एक क्राइटेरिया है, मैं बता देता हूँ।
बताओ।
मायोसाइट का एक क्राइटेरिया है, बचपन से लगभग 9.4 × 10⁴ से शुरू होता है ना, और है ना 9.4 × 10⁴ से शुरू होता है।
90,000 बस।
10⁴ मतलब 9 लाख। 9.5 हाँ 5 हो गया। हाँ और सर वो शुरू होता है, और वो डिपेंड करता है कि आप कितना सर एक्चुअली 2 चीज चलती हैं किडनी में, वो नहीं चलती हैं, हार्ट में चलती हैं। नहीं सर, हाइपरप्लेजिया किडनी में नहीं चलता है, हाइपरट्रॉफी चलती है।
हाइपरट्रॉफी होती है ना?
नहीं, किडनी में हाइपरट्रॉफी चलती है मेनली, हार्ट में हाइपरप्लेजिया भी चलता है।
अच्छा, नंबर बढ़ते हैं?
नंबर बढ़ते हैं, बिल्कुल बढ़ते हैं सर, पोस्ट MI भी बढ़ते हैं, स्टंटिंग के बाद भी बढ़ते हैं, बिल्कुल बढ़ते हैं।
तो 95 9 लाख होते, 4.5 लाख, 5 लाख।
हाँ, तो सर वो बढ़ते जाते हैं, और डिपेंडिंग अपॉन द रेस, एथनिसिटी, सेक्स, बहुत सारी चीजें हैं।
9 लाख से ज्यादा हो, 4.5 लाख। 2 लाख से ज्यादा हो।
सर अगला टॉक मेरा कराओ, मैं दे दूं।
गिव अ बिग राउंड ऑफ applause डॉक्टर।
90,000। हाँ वो 9
सर ये एडल्ट का है सर,
बच्चे का है।
आपके पास